with this meeting at the heart of the Big Apples, echocardiography, especially 3D echocardiography, has really been featured a lot. So we've assembled two experts to talk about that. What's the role of 3D TE? Sunil Mankad from Mayo Clinic and Judy from Mass General. So, you know, you guys were both leading a great workshop on cropping and all of that. Judy, let me start with you. You know, what do you see as the role of 3D echo in, let's say, mitral valve disease?
Well, I think it's certainly in the operating room, it's been widely adopted as a complement to our 2D TE assessment of the segmental mitral valve anatomy.
So let's go back to think about the workup of the patient, because you know, do we only rely on 3D TE, or is it really an anatomic landmark for us?
Well, I think it's still complementary to 2D TE. You know, a good 2D TE assessment can get a very good assessment of the segmental mitral anatomy. I think 3D TE can certainly be complementary, especially in those commissural scallops, and also for detection of clefts, which are much more difficult by 2D TE.
Yeah, absolutely. I mean, I don't think we really appreciate it. Sunil, do you agree with
Yeah, absolutely. I think what 3D does is gives you diagnostic confidence, and then, you know, the integrity, the surgeon and the echocardiographer, the mutual respect, the confidence that they have in their ability to repair valves rather than replace valves. Because as a society of caregivers, I think we still need to do a better job of repairing more repairable valves, because it's a mortality advantage. And 3D is really, I think, really found a great role there.
And I like where you're going. So the concept is, do we need to have a 3D TE preoperatively? In other words, for the surgeon, are we going to get to the point where you can give them all the data and they're going to be able to know exactly what size ring they're going to use, what size cord, neocords they're going to need? Are we going to get there?
I think, you know, I think the frame rates have to get better, but there's certainly the capacity to see the mitral valve in 3D as it should be is what 3D TE is all about. And, you know, I have some surgeons now, when I go down there, they're asking for the 3D TE. You know, I think it's just easier for them to appreciate.
Sunil, let's switch gears for a second,
absolutely.
Because the cath lab, certainly with mitral interventions in the cath lab, 3D is really critical.
It's really exciting because, you know, for the first time now, the interventionalists, they really need us to provide them images. In fact, they're learning to do 3D echo just as well as we do. You know, whether it's balloon valvuloplasty and looking at the commissural opening, whether it's the E-clip, basically reducing the amount of time these procedures take. In a very small niche, this periprosthetic leaks, these are very high-risk surgical candidates. If they had to go back to the OR a second or third time, really not an option, and the quality of their life is really low. And our groups in New York, you know, all over really, have shown that you can really improve the quality of their lives. And this is a procedure that really requires 3D guidance for it to work well. And not only that, you know, cut the time of the procedure, and we're all dealing in, you know, cost effectiveness, getting people in and out of the hospitals. So 3D echo really plays a role there. Once again, a complementary role to 2D, but really important.
Yeah, I think you're exactly right. I mean, obviously at the mitral clip, you knowing exactly where you are in the perivalvular leaks. Let's switch valves for a second. Okay, now let's move to the aortic valve. So 3D TE or 3D transthoracic. Let's stay with 3D TE. What's its role in aortic stenosis, aortic insufficiency, especially in the era of TAVI?
Well, you know, I would say sizing of the annulus. Right now we're still a little bit limited in the number of choices of valves and valve sizes we have. Nonetheless, one of the big problems we have is not accurately sizing it. And historically we've always used the 2D echo, the long axis view, and now we've learned from, you know, multi-modality imaging that 3D is a better way, that at least a third of the time the annulus is not circular, it's more oval. And to really get a better look at that, 3D is the key, whether it's 3D echo or 3D CT, some kind of imaging ahead of time.
Challenge you. I'm going to cut in. It's simply because I get challenged all the time, and it's obvious that all the literature is CT, which may be right, looking at not only shape and size, but calcification, things like that. Will we get to the place, or you may be at Mayo, or maybe you are at Mass General, where the guys feel that you're accurate enough for annular size?
I think we are, absolutely.
Really?
You know,
yeah, no, I think when we do our TAVRs, we use 3D guided assessment of the annulus. And that's a nice feature for quantitation that 3D can help, because it can guide you to a standardized measure.
It's interesting.
It depends on the skills of the operators, right? I mean, if you have great radiologists or imagers that are very good and understand the cardiac anatomy, because many times radiologists do not, but if they do, they can give you accurate data from the CT. But it's nice to have two tests that, once again, if they give you the same number, your confidence is higher. It's a life and death decision knowing the size of the annulus. If two tests occur, are the same, that really builds your confidence, and then you know what size valve to put in.
If in looking at complications after deployment, these valves, 3D is not really necessary. 2D is enough, or do you need 3D?
That's a good question. I think this is still evolving.
Okay.
I would say that we still use 2D to quantify the degree of regurgitation or leak of the valve, and of course the hemodynamics is all 2D derived Doppler. So we still use 2D for the most part, right. But this is emerging, and the technology is getting better and better. Right. The engineers designing this for multiple different vendors are creating new platforms and ways to make measurements. New indices are emerging that we never were able to report before. Intercommissural distances, things that surgeons had wanted perhaps, but never asked, and we as echocardiographers couldn't provide.
And let me ask you about the tricuspid valve, the old forgotten valve. It's not coming up. Does 3D TEE play a role?
Absolutely. I think one of the reasons the tricuspid valve is forgotten is that by 2D we never had a really good way of assessing it. It's got that funny shape. It's very hard to standardize the annular measurements, because depending on where your angle is, you could be 5 or 10 millimeters in difference. And the beauty of TE of 3D is that this allows you to standardize your measurements, especially certainly for the annulus and also tricuspid regurgitation as well.
Where are you getting those measurements? In other words, is it mid-esophageal? I mean, so tell me, where do you think you're going to go to get those measurements?
So what you can do now is you can get a mid-esophageal view, or even a short transgastric view.
Okay.
And you really want it to be able to guide it using a short axis view, using your the commissure and annular landmarks,
right.
Which is very hard by our 2D
very
views.
difficult,
but
yeah.
3D allows for that, and I think that's so. Now we can start. I think the echocardiographers can start talking to the surgeons in the same language, in the same plane, because now 3D allows us to measure that.
Final question. Both of you can answer this, but the concept of a heart team obviously includes in all the documents an echocardiographer, a clinical physician who's skilled in echocardiography. Is the echocardiographer going to be a specialist now in valve disease? In other words, is this a subspecialty as we get deeper and deeper into this, or is it going to be just somebody who gets modern day training in echocardiography?
I think for structural heart disease and the interventions on the valves, I think you're going to have to be a valve specialist. And there'll be a hybrid. I mean, the interventionalists will need to learn 3D echocardiography in order to do their skill as best as they can. And we as echocardiographers, if we want to assist in these valvular procedures and help guide the surgeons and the interventionalists, we have to expand our ability to understand 3D echocardiography.
Yeah, 3D analysis.
So yeah, I think it is a special skill, but I think those of us that have been doing 2D echo for a long time really can enhance our own skills, and it's really not that difficult to learn it. We learn from the masters like Dr. Hung, but truth is, once they have blazed the trail, it's easy for many of us to follow.
Super. Judy, so you think are you training your fellows at Mass General, or are you getting people who sort of master and...
Yeah, I think, I agree with your comments, Sunil. I also think that as we get into more and more complex procedures in which a heart team approach is the only way to work, I think there will be such specialization as an interventional echocardiographer. I mean, some of the issues are subtle, complex, and it increasingly, maybe not 100% of your time, but you'll want to subspecialize in it.
Good.
And, one final thought. I think one of the best things we've learned from the TAVR program is that a multidisciplinary team with surgeons, interventional cardiologists, and imagers together helping to decide what gives each patient individually the best chance, patient-centered care. And we no longer just, put square pegs in round holes. We can together, each of us using the skills that we have, make the individual decision for the patient or recommendation for the patient then together with the patient decide what's best.
Thank you both for joining me. You did a great job at this meeting, and you know, I think you've really elucidated the role that echo plays in valvular heart disease today. Thanks.
It's a pleasure, Randy.
Good to see you.
Thanks. This has been a great meeting.